Shelley, do you want to go ahead and kick us off?
Sure. Thanks, Jessica. Well, hello. Thank you for attending this session entitled Health Reimagined. My name is Shelley Dombrowski. I'm Regional Director for the North Bay area of the Alzheimer's Association, Northern California and Northern Nevada chapter. I will be your moderator for this session, and I just want to remind you, we're going to be opening it up for questions at around 2. So please feel free when you're listening to the panelists, if you have questions, the chat button is at the bottom. Put your questions in that chat. So while there's much we can do to stay healthy as we age, we all know that disability can come to any person at any time. And the longer we live, the higher our risk is of developing one or more chronic or disabling conditions. So we really need to ensure that our healthcare system is equipped to meet the needs of older Californians wherever we are, whether it's going in for annual checkups, taking a trip to the emergency room, or just trying to figure out how we're going to continue living in our homes when we can no longer manage the stairs. While the Master Plan on Aging lays out 5 strategies under Goal 2 of the Health Reimagined in the Master Plan, we're going to focus today on 2 of those 5 strategies. Strategy D, which is geriatric care expansion, and strategy A, bridging healthcare with home. Today's panel, I think there's a slide for the list, the panelists. I want to introduce them. Dr. Winalina Canio is the Chief of Geriatric Medicine at Kaiser Sonoma, also Medical Director of Acute Care for Elders Unit at Kaiser Marin, and a member on the Governor's Alzheimer's Task Force. Jennifer Winters, she's Major Gifts Director at Queen of the Valley Foundation and the project lead on Queen of the Valley Hospital's Geriatric Emergency Department accreditation. And then Chloe Cook, Social Services Unit Supervisor, Marin County Health and Human Services, Aging and Adult Services. So California's healthcare system is not prepared for our aging of our population. In particular, we have a severe shortage of geriatricians, as Dr. Canio will discuss, and need to figure out how to increase geriatric competence of our primary care workforce. So how to do that will be the focus of Dr. Canio and Ms. Winters' presentations. And as everyone knows, we have a big disconnect between our healthcare system and the kinds of in-home and community-based services that many of us will need to continue living safely in our homes. So a successful model for bridging that gap, the focus will be Ms. Cook's presentation. So each of our panelists are going to start off with an opening statement, and we're going to begin this with Dr. Canio.
Mic check. Can you hear me okay?
Yeah.
Great. Thank you so much. All right. Well, imagine 30,000 older adults in KP Santa Rosa with one full-time geriatrician. There is no way that one geriatrician will be able to care of their increasing complex needs. That was my dilemma actually about 9 years ago. And this is not unique to KP Santa Rosa. We know that the number of older adults is increasing as people are living longer. In 2018, there were 49.2 million older adults with about 7,000 certified geriatricians in the country and only 736 in the state of California. At that time, only about 3,500 were full-time practicing geriatricians. I remember coming to Santa Rosa and telling people that I'm a geriatrician. They're like, what is that? So I think we've come a long way. Research shows that 30% of people 65 years old and older need care from a geriatrician, and that each geriatrician as a primary care physician can only care up to 700 patients. In addition to this, we know that the health systems have been impacted. The Medicare reimbursement have been rapidly changing, and that the operating margin of health system have been trending down. What this means was I had to implement a geriatric model of care that will be able to provide care to as many older adults in the health system. Next slide, please. So the good news is that there are a lot of evidence-based geriatric models of care that have been proven to be effective. I did not necessarily need to reinvent the wheel. Comprehensive geriatric eval and management, or GEM clinics, geriatric outreach teams performing home visits, and geriatric day hospital care such as ACE units have shown to improve outcomes for our frail older adults, decrease mortality, reduce nursing home admissions, and higher level of function, making it possible for people to live independently longer. I was able to implement all of these programs slowly across the continuum in the last 9 years, starting with the GEM Clinic, the first of its kind in KP, Northern California. Next slide, please. So what makes all those models of care different is that clinicians are not just treating diseases, but they're all consistently assessing and managing the 5 M's, which are mind, medications, mobility, what matters most, and multi-complexity. These are the core issues that drive older adult care, and they really reflect expertise of specialists in geriatric medicine like me. So what that means is that when an older adult is referred to our GEM clinic for frailty evaluation, our interdisciplinary team are discussing what matters most, knowing and aligning the older adult's specific health outcome goals and care preferences, and documenting them in an advanced healthcare directive. Evaluating the mind using standardized tools to assess for anxiety, depression, dementia, and delirium, reviewing medications to see if all of the medications are still necessary. Do any of them affect what matters most to the patient, whether it's the mobility or mentation, and assessing mobility, ensuring that older adults can move safely every day in order to maintain function and what matters most to them. And last but not the least, addressing all of the multi-complexities, whether it's multiple chronic conditions, frailty status, transitional care, including safety and life stressors. So in addition to applying the 5 M's in GEM Clinic, we connect all of our patients and their caregivers with our community organization partners, Alzheimer's Association and Redwood Caregiver Resource Center. They provide ongoing caregiver education and support, such as providing respite grants and counseling especially for folks who are caring for people with dementia. About a year ago, this successful model of care has been expanded to KP San Rafael. The dementia care program developed from this model is now being standardized throughout Northern California. If you'd like to implement this or other models I've developed, feel free to contact me after this meeting. North Bay fellow advocates, policymakers, and community leaders, as we reimagine and redesign our health systems to be more age-friendly, 10 years from now, all of the older adults in our community will be provided the quality care they deserve from every one of us. Thank you.
Thank you, Dr. Canio. We'll now hear from Jennifer Winters.
Thank you, Shelley. Hi, I'm Jennifer Winters. I, as was mentioned, was the project lead for the Geriatric Emergency Department accreditation at Queen of the Valley, now under Providence. And I am a major gifts officer within the foundation. And I stumbled upon this project just by being an advocate and talking to the emergency department chief of staff and medical director. And we found that there was a definite need. And this was back in 2018. And it developed into us actually receiving our accreditation in March of 2020. And I'll go ahead and go through these slides. They're very interesting and important information. And so why would we want geriatric emergency departments? So over 68% of emergency department admissions are people over the age of 60. That's a huge amount of our inpatients coming in. And once the older adults are in the emergency department, they're more likely to have an emergent or urgent condition and to become hospitalized and admitted to a critical care unit. So coming into the emergency department and getting to go home is not what we're seeing with those that are over the age of 60. They also receive a greater number of diagnostic tests, spend longer times in the ED, and have higher charges for the ED services than younger patients. It is because there's just such a high need of the areas that are needed for the older patients, and it is a lot different than what you see with someone who is younger. After an ED visit, older adults are at greater risk for medical complications, functional decline, and poorer health-related quality of life than they were before. This fact is very concerning. You don't want someone going into a hospital where you're supposed to be being helped and leaving in worse condition. And that is why the Geriatric Emergency Department accreditation is really focused on making sure that is not happening. So for the next slide, please. I don't think I have control of that. There we go. So the bronze symbol on the right, the Queen of the Valley is a bronze certified geriatric emergency department. And that is GED for short, as you've seen. And the accreditation is through the American College of Emergency Physicians. And the process is quite straightforward. You go to their website, there is a fee, and I want you all to be encouraged to know that a lot of the bronze needs that they are asking for, most hospitals should be doing. And it is additional training for your medical director and a registered nurse that makes it possible to receive the accreditation. And so it does help with better clinical staff education as well, and the nursing care, and evidence-based protocols as well that are common for geriatric syndromes, and being more familiar with that. Also, structural modifications such as quieter rooms, soft lighting, dementia-friendly design. Those areas are under the gold accreditation, the gold level. And luckily, this was possible for us to receive our accreditation. And so there was a big motivation because our emergency department was receiving a complete refresh. And we are using the guidance of the GEDA to show how we can have different colors and even the noises of a curtain, or when a garbage can closes and not making a noise. Those are things to help eliminate agitation with those that are older, especially those that have signs of dementia. So it also reduces the risk of delirium, complications caused by medical treatment, the cost, hospital length of stay, that is a very big one, and transfers to long-term care facilities. I'd like to touch on hospital length of stay. You know, the hospital has a lot of transition, and, you know, we want people to be able to go home, and then being transferred to a long-term care facility, you know, that is going for extended care. And if we can do well while in the hospital, the patient should be able to go home as compared to having an extended stay in a different facility. It also preserves patient function and provides the best care for the most vulnerable. And I'd like to close, at least for this moment, with a quote from Dr. Andrew Fenton. He was our champion for receiving our accreditation. And he says, while embracing these concepts to improve care provided to the older adults in our emergency department, we will enhance the care we deliver to all. Thank you.
Very exciting. Thanks, Jennifer. And now we're going to hear from Chloe Cook.
Hi, everybody. I'm so glad to be here. I think the important thing about the presentation that I'm going to provide today is that we are the catchers in the field. We're the programs that receive the patients who come out of the emergency room, come out of the skilled nursing facilities, come out of Kaiser's appointments and long-term care. We're the ones that can facilitate and support community living. And with our Aging and Disability Resource Connection, our one door here in Marin, we are a collaboration between an independent living center and a government program with aging and adult services. So
no, they were close. I'm gonna get them tomorrow.
we combine the government programs, which are, some of them are entitlement programs based on Medi-Cal eligibility, such as in-home health supportive services, CalFresh, all of the sort of government programs that are provided by Health and Human Services. That's what the Aging and Adult Services program brings to the One Door. And then Marin Center for Independent Living, their hospital to home transition programs, their caregiver registry, their support around benefits counseling and benefits acquisition. Those are all really important elements to supporting individuals living safely and happily in the community. It doesn't mean that individuals don't need help. It means that they get the help they need to have as much independence as possible, regardless of their conditions.
I have to take my mom tonight.
Nora, yeah, good. So anyway, I'll continue on. So I think, really when we're talking about collaborative programs and collaborative relationships around supporting older adults and individuals with disabilities in the community, though using a collaborative model is the way in which you serve clients in a wraparound, full service way. Next slide, please. So when we get the next slide, you'll see these are the core services that an Aging Disability Resource Connection provides. These are mandated services by all certified ADRCs. Our One Door is a California certified Aging Disability Resource Connection. We call it a connection. There's ADRC centers, there's ADRC connections. We don't have a physical plant, but we have an umbrella under which our services live. Our umbrella is our ADRC, our One Door, and then in that One Door, under that umbrella, we provide enhanced information and assistance. And what that means is that we have a centralized telephone number, and someone can call in to MCIL or to the 473 info unit and receive options planning services, which essentially addresses any need brought to us, any concern, any question. Our staff are trained specialists in resource navigation and resource information. So it's a one-stop shop where individuals can get their questions answered, discuss their options, and actually sign up, do the intakes for programs, and start that ball rolling to get the services in place so that they can, again, live comfortably and safely and independently in their community. We work with hospitals, we work with clinics, we work with doctors. We actually have a program that is a health profession intern program. This semester, we had 63 health profession interns working with our clients. We served over 200 clients just in the spring semester alone. And those interns are providing a bridge, as well as our staff, between the hospital and the community living. So again, these services that we provide are intended to be a one-door approach, one call approach, one walk-in approach to connecting individuals to the services they need. So options planning is a service where an individual will relate to us their situation. They are marginally housed in an apartment they can't afford, and they need some in-home support. So we will assess their income, assess their financial resources, assess their living situation. Sometimes that means advocating with landlords for rent reductions. Sometimes it means helping an individual look for a more affordable place to live, look for options which could involve shared housing, which could involve renting a room in a home with other older adults. So, there's all kinds of options. And we are, again, are trained in looking at the width and breadth of opportunities for individuals, regardless of their need or their situation. We can think creatively and encourage them to share with us their goals. It's person-centered. Each individual who comes to us gets a very personally catered set of conversations and supports around where they want to go and what they want to do. It's client-led. services. And then a benefits assessment, again, is part of that options planning. And it actually looks at what someone is already receiving, what they're eligible for, and then helps them actually connect to those services and supports so that they can maintain their independence. And short-term service navigation is 6 to 8 weeks. That's what we do. That's where it encompasses information and assistance, options planning, benefits assistance, transitions from medical facilities to home. It could involve home modifications. It could involve caregiver registry. So that short-term service navigation is all about connecting individuals to the services and supports they want and they have identified as priorities for them. So let me just go quickly through. So the transitions from hospital to home has to do with a lot of different things. We work with discharge planners and skilled nursing facilities. Again, we work with clinics and doctors. We work with hospitals, Marin Health, Kaiser. We work with their social workers and their physical therapists and anyone who's a part of that discharge team or that transition team. We are sort of the ringleaders. We bring together all of the different services and conversations around very siloed and specific services. If you are a medical provider, you will be focusing on a person's medical care. And we can bring in a conversation about socialization, about nutrition, about transportation. And so by creating that wraparound team, then we make sure that all of those social determinants of health are addressed as someone is looking at coming home or transitioning to another living situation, transitioning to a family member's home, a child's home, transitioning maybe not directly back to their own home, but to another situation that better fits their needs and wants at that time of transition. And home modifications is pretty clear. These are grab bars, ramps, elevators, not escalators, but little lift chairs, anything that a person might need that could facilitate a safe return home or safety additions to their home as they age in place. And that's really important that the home is assessed and the individual's wants and needs are discussed. And then again, having a list of contractors and providers that can do that work in a timely manner, and also funding around those home modifications. We have a program currently going on that can provide funding for low-income individuals to help them with those home modifications. And then when you think about the caregiver registry, so these are vetted caregivers that run the gambit. So we don't just serve low income or moderate income or middle income. We serve individuals in the entire income span. So our goal is to provide services at whatever level a client is. If that's coordinating private pay care, private pay housing, private pay, transportation, we can do that. We have those services known to us and in our toolkit. If someone wants private care 24 hours a day, we have caregivers that are vetted and available that we can connect a client with. If someone needs an in-home health supportive services caregiver, which is an IHSS caregiver, a benefit of Medi-Cal, then we can go ahead and put that service in place as well. So next slide, please, and I'll talk a little bit about the staffing in this next section. So again, the services we provide are provided by trained social workers, health profession interns, licensed RNs and public health nurses, and licensed medical providers across the spectrum. These are through our nurse and health profession internship program. We have contact with doctoral providers. We have contact and we have support from interns in nurse practitioners, RNs and masters in nursing. We also have public health nurses interning with us. So it's all levels of certification and licensing are available at different times through our services. But the primary services are provided by social workers at the county level and at MCIL. They have short-term resource coordinators. These have a set of trainings that are provided and overseen by the California Department of Aging, and all of our staff are certified in options counseling, options planning, and a variety of different areas of expertise. So that's kind of a profile of our staff. And again, I've alluded to this and spoken to this already in the presentation, but person-centered advocacy and services is service coordination is pivotal and central to the work that we do. We hold our client and their needs and wants in primary focus. We may know professionally what someone needs and should have, but that's just in the back of our minds. Our focus and our work is all around talking to, getting to know, and spending time with our clients so that they can really voice and feel safe to share with us what their real, central wants and needs are. And then, of course, I spoke to this already, in-home health supportive services. We can support people through the enrollment process. As all of you know, government programs can be very daunting in their application process, and we provide very direct and professional support for individuals going through that application process. We help them understand what the timing is, and what the required documentation is, and we can really hold the client through the whole process so that they can make it through kind of a long and sometimes arduous process. And then the caregiving registry, I spoke to that earlier, but the electronic visit verification is a new requirement for in-home health supportive services, and it is not easy for older adults navigating the online or telephonic approach to this electronic visit verification. So we can provide training, ongoing support for this, again, computer-based way of paying their caregivers through the in-home health supportive services. And then I spoke to interns. Our ADRC health profession interns bring a huge width and breadth of medical knowledge and medical support. They work with under the guidance of their doctoral professors. They work with medication management, chronic condition, self-management. They work with, they help people sign up for programs. They help people fill out applications for housing, for adaptive equipment. They will work with clients, and through this whole vaccination and the pandemic, they have worked with clients on understanding the importance of vaccination, accessing vaccinations, getting vaccinations in their homes for homebound individuals. So our health profession interns just bring such bandwidth to the work that we do. And again, it's wonderful to see that cross-sector collaboration between healthcare and social services. And then as we talk about advocating and support accessing services, all services, any services needed for that client. And frankly, we've even developed programs within our ADRC when we see a need. For example, our 911 first responder program is a direct referral from our first responder partners in the community, sheriff, police, and our EMS, emergency service providers, ambulance, and fire. So we have a direct referral process and direct relationships with our emergency providers in Marin County because we saw a huge need between the individuals that were identified by our first responders as needing help. And those would be people that have had falls, medication mismanagement, have had, dementia conditions, and found themselves disoriented and lost in the community. These people now have a streamlined referral process to our ADRC services. So again, we are not only providing and coordinating services, but we're developing services as we see them through our work in the community. It's pretty exciting work, and I'm really proud of our teams and the collaboration between, again, a nonprofit and a government agency coming together to serve our community and bridge those pathways between healthcare, social services in the community, and again, facilitating independence to the best, as far as we can for our older adults. And again, our transition program works very closely with the Ombudsman, which is the patient advocate for skilled nursing. So we also are in skilled nursing facilities working directly with the Ombudsman to make sure that individuals who want to transition are getting.
Why don't we try to stop her from talking and start questions?
That's the end of our presentation. So I am thrilled to be here and happy to answer any questions as they come up. Thank you.
Great. Well, thank you, Chloe. Yeah, we're gonna, I have some questions that before going into the Q&A for all panelists. So if we could pull up Dr. Canio and Jennifer Winters. The first one, so great ideas, great practices. In referencing the Master Plan on Aging's playbook, there are three main elements in achieving results, and it's forming key partnerships, which some of you have mentioned who your key partners are, exploring data, and reviewing results. So I just kind of, who were your key partners and locally in getting this kind of innovation off the ground? And also, who are they now? And Chloe, why don't we start with you?
Okay, so well, again, Aging and Adult Services, Health and Human Services. We started this conversation in 2015. Mm-hmm. So our ADRC started with a conversation between Eli, the executive director of MCIL, and our Aging and Adult Services. And when that conversation started, everything started to roll out. I was actually hired in 2015 to work with the development of the ADRC and enhanced information and assistance program. So our key partners, in the ADRC are MCIL and Aging and Adult Services. But I have to say, partnerships are built every day. Our 911 first responder programs, all of EMS, police, sheriff, fire, we are partners. I look at everyone in the community that's providing or interacting with any older adult as my partner. And we are constantly building partnerships across Marin and the Bay Area and California. Julia Hales works tirelessly at the state level to advocate for ADRC services. And so when I say one door, that one door leads to all of our partnerships. And I have strong partnerships with Marin Health, our local universities that are training our health professionals. They're all my partners. I meet with them weekly. So these are deans of departments of health professions. So, they're meeting with us in partnership to talk about services and supports for older adults. And I think, again, the strong partnerships we have across Marin are what makes our services available and able to happen. So I just have to say, anyone who's serving older adults is a partner, and you need to cultivate those relationships. And Shelley, what
I know firsthand. Yes, you know what it is. Jennifer Winters, how would you describe your partners? Getting your certification off the ground, and then now. Are you there, Jennifer? Let me see.
I was trying really hard to remember to unmute.
Yeah.
So when we first started, it was Dr. Fenton, and he had written about a letter size of a proposal. And then it was the president of the foundation assisting me to meet with the CEO to get the approval for this accreditation. And then now system-wide, we have age-friendly health system that when you saw the 5 M's, we have something similar as well. And now we have Providence, who has 52 hospitals behind us with trying to become more geriatric friendly. And then the community in itself, you have dementia capable Napa County, that's through Collaborate and the grant, and that is working with the hospital for training. So we definitely have a lot of anyone who is age friendly and wants to partner with the hospital, I'm usually the person they contact, and then I try to branch it out throughout the system.
Okay, good. And Dr. Canio.
I'm kind of the same as Jennifer, the contact person for any older adult community partnership. But when I started about 9 years ago, I remember going to Shelley's office in Santa Rosa. I said, this is my vision. I can do the medical care and a lot of the complexities, but I need help with helping the caregiver make it so that patients can stay at home as long as possible. And we just kind of discussed what resources that they already have, and then how we can combine them together. And I did the same for Redwood Caregiver Resource Center. And that actually helped develop our memory care program of Sonoma County. And that still it's the same partnership. As I expanded my role in Northern California, Kaiser Permanente, we are now trying to standardize dementia care in the entire Northern California with partnering with the Northern California Alzheimer's Association and other California Caregiver Resource Center. And since I moved to San Rafael a few months ago, I started talking to our local community organizations, Marine Village, and actually Marine ADRC with Julia, of hopefully making that partnership more formal.
Yeah, I know with COVID-19, it kind of did put a delay on things, even for Jennifer as well. But we really appreciate our partnership with Kaiser and Dr. Canio. They were one of the first to implement the fax referral program. And so when a patient is diagnosed and gone through an assessment, they're immediately, if they want to be contacted by the Alzheimer's Association, Redwood Caregiver Resource Center, or Family Caregiver Alliance, we get the form and we contact them within 48 hours. And I know that was always something that was an issue with families that we serve, in that they would leave the office and then now what? So now we actually can form that connection with them right away, which is wonderful. So thanks. And while you're still here, I think meaningful metrics are the kind of the foundation for the planning and evaluation of our work. What data was helpful in making the case for your new innovations in geriatric care?
I don't know what data actually helped, but I gathered a lot of data over time. I started with the number of adults in the Kaiser Permanente Center as a health system and how many older adults we have in the entire county, as I'm trying to figure out, how many more members are going to join Kaiser. Number of adults with diagnosis of dementia, as you know, those are the more complex, more challenges. And so trying to figure out what specialized resources for them. Number of adults in other programs such as special needs program, complex chronic conditions, how many older adults completed advanced healthcare directive, data on medication utilization adherence and use of high-risk medications in the elderly. And I think this is probably the most important one, is just baseline data on ER utilization, urgent care utilization, hospital and SNF admission and length of stay.
Thanks. Jennifer.
Our data was similar to what I read on the first slide, with the number of people that are over 60 and such a large percentile of that coming through the emergency department. I'll tell a funny story. The CEO wasn't in the best of moods when I had to present to him, but you could not deny the need of, and we would love to have a wing just that is dedicated to those that are not just older adults, but those that come in who are struggling, and especially with dementia and delirium. And, we have a long way to go, and the stats are behind us. So luckily, we are continuing to advance as far as how we can help within age friendly.
And Chloe.
Well, I think the sort of original impetus to this was our AAA survey that we do. And it's a survey of older adults and their assessment of needs in the community. And information assistance and access to resources came up over and over again over the years leading up to our development of our enhanced information and assistance in ADRC. And so I think in listening to the community and paying attention to the concerns of older adults really helped us make the case. And again, the aging population and their choice to live at home and remain at home was we were listening to what the community wanted and what their real goals were for their for their aging process. And, most people want to age in place. They want to stay at home. They don't want to be institutionalized. So again, that was a real driver for us. And, how can we enhance that information and assistance access? How can we provide services so people can stay at home? What services do we need? And the ADRC fell just naturally into that. And so I think we really saw what California saw in the development of the ADRCs across the state, and really, rode those numbers right up to where we are today. And I think the justification in the outcomes, we're doing now a survey with our clients on quality of life that we developed. And so we're seeing remarkable results as far as an individual's expression of quality of life once they've achieved, attained our services, and we've been able to put in place some services and supports for them to remain at home. So I think those numbers really tell the story of quality of life.
Great. And want to remind everyone, if you have any questions, we have a couple questions in the chat. I have a couple more questions I'd like to ask the panelists, so feel free to put your questions in the chat. What should people who want to bring, and Chloe, I'll start with you, bring this best practice to maybe their local county health system? What advice would you give to them?
Well, I think it's a great time to be having the conversation at a county level because there's funding now for emerging ADRCs. We are more than willing, Julia and the rest of us in the ADRC are more than happy to support conversations with anyone to do Zoom talks at this stage, and someday do field trips, host visits to see what we're doing and how we're doing it. So I think with the funding that comes down through this master plan on aging, I think that now is the best time. We can certainly put you in touch. Go to California Division of Aging, ADRCs. There's great opportunity. I think that's really when funding is available, that's where programs get developed.
Right. Jennifer.
As far as advocating for your community and within your county, there is only a handful of GEDAs within Northern California, and going to your hospital and asking who to speak to, or going to the top, send a letter to the CEO, because becoming a geriatric emergency department and being accredited is a matter of going onto the website for the medical center and filling out an application. There's a $2,500 fee for the very first level, and it should be able to go through without a whole lot of red tape. And it is enough that even with the emergency department as busy as they are, it's they're very hands-on and friendly about how user-friendly they go about it. So I would say just, making that move. Why aren't we accredited? And start asking those questions to your community leaders and, be able to get it done. And you'll have my contact information if you need any help.
Good. And Dr. Canio.
Well,
Advice to other health systems. And your own.
Yeah, so it's a lot, but for sure, follow the MPA playbook. It has it all. Engage local leaders, try to speak the language and align with their goals. Stakeholders, including patients, that matters a lot. We think we know what they want, but we need to ask what they want. And caregivers, we can't forget them. Partner with community organizations that are already providing resources, get the data, review existing models, and see if there's an opportunity for innovation from other models of care. Talk to me. I tried all of them, probably. Think outside the box, assess your programs, and adjust as needed. Connect with folks that are already doing this. And most of all, have a mentor or two available when times get tough, as it does get tough. Even though we have now a public policy, the blueprint, I think it's still going to be tough, and just don't give up.
Okay. Well, I have you there. I have one more question. So I know we talked about the first strategy in the master plan, bridging healthcare with home, which is an area that's been particularly challenging for many years. How does your innovation bridge healthcare with home care? Or what?
Yeah, so I guess the first one is we're leveraging the existing government funded resources like the CCRC to help provide ongoing support to the caregivers. We do this by having patients' families complete a referral form, like you mentioned, so that partners can call them rather than asking them to call the organization. In an integrated KP system, we also have transitions and home health teams available for a short period of time. And also we have complex chronic conditions that I also now oversee for the ones that need more case management. We are currently in the process of implementing the 5 M's in these settings. So it's quite exciting as that has not been implemented yet. In San Rafael, we have the primary care at home, and hopefully we will launch our Thrive at Home program in Santa Rosa soon. So lots of exciting stuff.
I wanted to mention as we're talking, Jessica put in the chat, Canada published a great toolkit for comprehensive geriatric assessment. We've also put in the chat the playbook that was referenced, and also just the master plan on aging. It's also in an email that's included on your reminder registrations, but yeah. Jennifer.
As far as bridging healthcare to home, you know, Chloe's program, I was just discussing with someone who was also in this breakout room about how Napa County really could use some help with that. And because it is, when you have social workers who are working on discharges and being able to kind of hold someone's hand and get them through the process of what's available when you go home, and more importantly, skilled nursings, you know, some skilled nursings are different. We have, you know, quite a few here in Napa, and knowing, you know, where to go, what to do, and what to ask. So we're constantly striving for improvement in that area. And as you go up in the levels with the accreditation, they do focus on that as well. So we are, you know, consistently looking for ways to improve within that. We do all that we can, but there's definitely, again, more that can be done.
And Chloe, yeah, so this is your question because you're already doing this. So I want to just, there are a couple questions for you, Chloe, in the chat. Can your services be scaled to include Sonoma County? This is for Chloe.
I would say no. I would like to see an ADRC in Sonoma County.
Yeah.
Yeah, I think that's the best way to do it. That's the model, is that every county have an ADRC, and again, collaborating with their independent living center, because every community is different. Every county is different. And, you know, we're the specialists for Marin, and that's the whole point. So, because again, services when you're person-centered are very nuanced and very community specific. So it would be a stretch for us to take on Sonoma County. And again, I think it would go against what the ADRCs are intended to do, which is to be county specific. And you know, and we're happy to help. You know, I mean, it's every new program is work, but it's not work that you have to pioneer. You know, we have policies and procedures, you know, you can share those. So I think, you know, yeah, absolutely. We want to support the development of ADRCs across the state. This is the way to help communities age well. So,
and I'm so glad this is being recorded, because I know we can't go to all the breakout sessions, but we're going to be able to, everybody's going to be able to review everything the panelists had to say. One other question, Chloe, what's your staffing level and type of credentials? MSW, CMs?
Yeah, so I have social workers, and some of them are licensed, some of them are not. I hire staff based on their abilities, their willingness to learn and grow in their position. So I don't not hire licensed people, and I don't only hire licensed people. I hire people that fit the job. And we have a very diverse multilingual staff. And if you want to look at the health professions, interns that come in, and the doctors that are associated with those interns, they come from all licensure perspectives within the School of Health Professions, and they come from all backgrounds. So many languages spoken, many backgrounds, and you know, part of the program is also a digital literacy and digital device access. So, you know, it's very diverse, and I think that's how you best serve your community, is when you look like your community, and that doesn't hold a license or a degree. It really encompasses many different people can provide this service, and that's what makes our staffing robust.
Great. I do want to make a comment. So Krista Nelson from the Senior Advocacy Services put in the chat, Sonoma just became an ADRC certified county. It's in the process, and we understand it's coming. So thanks for that information. And I guess I want to thank you for attending. Actually, time flew. Thank you. I want to acknowledge Jessica. She's the Alzheimer's Association Senior Public Policy Manager. She was on the planning committee for Health Reimagined and really put together this program. She's going to be doing the recap once we get into the main room. But thank you, Jessica. This could not have been done without you. You've done an incredible job.
Oh, thank you so much, Shelley.
You're
Jessica.
welcome.
And thank you, Shelley. You did a
You're
great
welcome.
job.
Yeah, thank you to
Thank
all,
you.
to you, Shelley, and to all of our panelists.
They
Thank
did a
you,
wonderful
everyone who
job.
joined us. We'll see you all back in the main room.
Okay.